Welcome to our video on inhalation injury and carbon monoxide poisoning. Let's get started. So let's start with inhalation injury. For both of the conditions we'll cover today, we'll be discussing the definition, risk factors, pathophys, the clinical presentation, as well as the diagnosis and management. So let's start by defining inhalation injury. Put simply, inhalation injury occurs when heavy amounts of smoke are inhaled, resulting in subsequent burn injury inside of the upper airways and lungs. As you can probably imagine, the unique risk factor for this condition is a severe burn, such as may occur if a patient were caught on fire or had been rescued from a burning building. In a way, it's as if these patients have been burned from the inside out because of the significant heat of the inhaled smoke. Let's go into this further, because the resultant sequelae can be catastrophic if it's not properly managed. So the intense heat of the inhaled smoke can cause direct thermal injury to that tissue. And when this occurs, edema and blistering soon follow, and that has the potential to compromise the supraglottic airway. And you don't want them to suffocate, essentially. Were this to happen, the patient would obviously lose the ability to breathe, and that could kill them if you're not intervening. The subglottic airway is far less susceptible to damage because it reflexively closes when exposed to hot air. Let's draw this out to drive home the point. Here we see a sagittal view of the head and neck. And we'll use this image to focus on the pathway that the air will travel through as it moves towards the lungs. This includes the nasal cavity, the mouth, the supraglottis, the glottis, which includes also the vocal cords and the space between them, and the subglottis, as well as the trachea. In the case of inhalation injury, the person first inhales smoke, and as a result of the intense heat and subsequent thermal injury, edema and blistering occur in the supraglottic region. Eventually, the disrupted area is so large that the person can't breathe. This airway compromise can be the cause of death if not rapidly corrected. Using this same image, we'll explain why the subglottic airway tends to be less affected. As shown earlier, smoke enters through the nasal cavity and mouth and works its way towards the lungs. When it reaches the subglottic area, this region reflexively closes in response to that intense heat. This means that each of these areas, distal to the subglottis, are less likely to be damaged by the inhaled smoke. Okay, on to the clinical presentation. The clinical presentation of these patients is distinct, and question stems often key in on the first 2 points listed on this slide. That is, patients will show singed facial hair or eyebrows with inflammation and even blistering of the oropharynx. So naturally, because you're worried about an inhalation injury, you're going to look inside their mouth, and you're going to be looking for inflammation and possibly blisters. In addition, there may be soot or carbon deposits inside the posterior oropharynx. Of course, burn wounds on the face can be seen given the mechanism of injury. Now finally, stridor may be present, particularly if the supraglottic airway compromise mentioned earlier has already occurred. Here we have a bronchoscopic image of the trachea. On the left image, we can appreciate significant congestion and edema. In both the left and right images, there are darkened areas of carbon soot deposition. Finally, the formation of a pseudomembrane is seen on the right image. Now, some of these findings may be appreciated on physical exam of the posterior oropharynx in some patients. Otherwise, you can see this on bronchoscopy. As with any trauma patient you'll see in the emergency department, your assessment should begin with evaluating the ABCs of trauma: airway, breathing, and circulation. It's possible that you won't even get past the airway portion of your clinical exam before needing to perform immediate intervention, which we'll discuss on the following slide. As far as diagnostic measures that can confirm your suspected diagnosis, the carboxyhemoglobin level in these patients will be greater than 10%. This is because the smoke from fires contains substantial amounts of carbon monoxide, which when bound to hemoglobin forms carboxyhemoglobin. Lactate levels will often be high. As illustrated on the previous slide, bronchoscopy can be a critical test in confirming the diagnosis of inhalation injury. A chest x-ray is often obtained in these patients for comparison purposes before and after treatment, though its sensitivity for inhalation injury is pretty low. A 22-year-old male is brought to the emergency department after being rescued from a burning apartment complex. While the patient is being stabilized, initial labs are notable for a serum pH of 7.2. What is the most likely etiology of this patient's acidosis? Okay. Now, the most likely etiology of this patient's acidosis is metabolic acidosis secondary to lactic acidosis. This patient most likely sustained inhalation injury while stuck in a burning apartment complex and likely inhaled carbon monoxide and hydrogen cyanide in the process. Both carbon monoxide and cyanide inhibit mitochondrial oxidative phosphorylation, thereby inhibiting aerobic metabolism. This forces cells to rely more on anaerobic metabolism, which leads to excessive production of lactic acid as a byproduct and results in lactic acidosis. Of note, carbon monoxide poisoning will be covered in greater detail later in this lecture, and cyanide poisoning is covered in great detail in our methemoglobinemia and cyanide poisoning lecture. In any patient with evidence of burns or thermal injury, 100% oxygen via a non-rebreather face mask should be administered. This is because these patients are presumed to have concurrent carbon monoxide poisoning, which will be discussed in greater detail on later slides. More importantly, consider performing an emergent intubation in these patients because of the potential for airway compromise that we described earlier. Do not wait to perform this because the edema that results from this disease process can eventually make it difficult, and it might even make it impossible to intubate. So, early intubation. So this brings up a clinical pearl. When answering emergency medicine questions, such as what is the next best step to perform in this scenario, it is useful to ask yourself what is most likely to kill the patient. Then, select the answer choice that is most likely to prevent this death from occurring, such as emergent intubation in the case of suspected inhalation injury. We will now cover carbon monoxide poisoning. And our format for covering carbon monoxide poisoning will again start with definition. Carbon monoxide poisoning is a syndrome that is characterized by severe hypoxia after a patient has been exposed to carbon monoxide gas. On the next slide, we'll highlight some common causes of exposure to this toxic gas and also help you remember that this gas is tasteless and odorless. Carbon monoxide is formed when carbon-containing compounds don't completely combust. There are a variety of instances in which carbon monoxide can be inhaled. It can come from inhaled smoke, from something like an enclosed fire or a barbecue grill. It is present in automobile exhaust, which may be at high concentrations in a closed garage. It can also be found in aged or defective appliances, such as a heater or gas motor, particularly when these are present within poorly ventilated areas, like a trailer or a really small home. One clue to look for in a question stem is the mention of it being wintertime, as this is when something like a defective heater may be used for the first time after a long summer. And this is a good reminder. When a question stem mentions it being a specific season or month of the year, there's usually a reason for saying it, so pay attention. There are three major mechanisms by which carbon monoxide poisoning results in deficiencies of oxygen throughout the body. First, the affinity of carbon monoxide for hemoglobin is much greater than the affinity of oxygen for hemoglobin. This leads to less oxygen being bound to hemoglobin, or in other words, there's a decreased oxygen carrying capacity. Second, carbon monoxide causes a left shift in the hemoglobin-oxygen dissociation curve, which results in decreased delivery of oxygen to the tissues. Finally, carbon monoxide alters mitochondrial oxidative phosphorylation. This leads to decreased oxygen usage and a resultant drop in ATP production. And we'll use the next 3 slides to illustrate these important principles. Here we'll illustrate how carbon monoxide results in decreased oxygen carrying capacity. Typically, hemoglobin has 4 binding sites that can be occupied by oxygen molecules. When carbon monoxide molecules are present, they bind with a much greater affinity to hemoglobin, and thus displace many of the oxygen molecules. Because less oxygen can now be carried by the hemoglobin molecules, the oxygen carrying capacity is said to have been decreased. As a result, less oxygen can be taken to tissues that need it, and patients begin to experience symptoms of hypoxia. To illustrate another way in which carbon monoxide poisoning impairs oxygen delivery to tissues, consider this oxygen-hemoglobin dissociation curve, depicting the percent hemoglobin saturation on the y-axis and the partial pressure of oxygen on the x-axis. Carbon monoxide poisoning will shift this curve to the left. This means that at a given partial pressure of oxygen, the percent saturation of hemoglobin is higher. As a result, there is decreased oxygen delivery to tissues because the oxygen is more strongly attached to the hemoglobin molecules. Combining this with the concept from the previous slide, carbon monoxide prevents hemoglobin from carrying the amount of oxygen that it normally would. And then, even when a hemoglobin molecule is lucky enough to have oxygen bound to it, it has a difficult time offloading it at the tissues. So all those tissues that need it won't get it. So we see this left-shifted oxygen-hemoglobin dissociation curve. And taking together the decreased oxygen saturation of hemoglobin as well as the left shift, then it's logical that significant hypoxia will result. To illustrate the final concept in the pathophysiology of carbon monoxide, let's utilize this image illustrating the electron transport chain on the inner mitochondrial membrane. And you may recall this image from our biochemistry chapter. Normally, a molecule of oxygen gets reduced to a molecule of water, and that's in complex 4, thereby completing oxidative phosphorylation and allowing for aerobic metabolism. However, if carbon monoxide is introduced into the cell, it impairs the function of complex 4, and it prevents oxygen's participation in the oxidative phosphorylation process. As a result of this decreased usage of oxygen, fewer hydrogen ions are shuttled into the intermembrane space, which results in less of a gradient for ATP to be produced at complex 5. And this drop in ATP production is damaging to those affected cells. The clinical presentations of this pathology are related to the body's tissues being deprived of oxygen. In mild cases, patients may show a headache or confusion, and members of the same household may have symptoms similar to a flu-like illness. As the disease process goes on, patients may show cherry red skin, and that's from all of the carboxyhemoglobin in the tissues. They may also demonstrate myocardial ischemia, pulmonary edema, syncope, seizure, or coma. And these result from a loss of oxygen to the heart, lungs, and brain, respectively. Which area of the brain is particularly susceptible to damage secondary to carbon monoxide poisoning? Okay, considering the information discussed on prior slides, carbon monoxide exerts its damaging effects by leading to tissue hypoxia. So, in answer to this question, one should consider areas of the brain that are particularly susceptible to hypoxic injury. One such area is the globus pallidus, which is part of the basal ganglia, and it sits lateral to the thalamus and it's inferior to the internal capsule. Here's an image of a brain MRI depicting the transverse section of the globus pallidus, and it's highlighted in red on the patient's left. Of course, globus pallidus is also present on the right side of the brain. In a patient with carbon monoxide poisoning, this particular area of the brain may sustain hypoxic injury and subsequently appear abnormal on a brain MRI. And though the globus pallidus may be the most testable area of the brain that is sensitive to hypoxia, other susceptible areas do exist, including the cerebral cortex, the hippocampus, and the cerebellum. In addition to viewing the clinical picture in conjunction with exposure to known risk factors, a few diagnostic tools can be useful in diagnosing patients with carbon monoxide poisoning. First, note that the oxygen saturation in these patients is usually normal. This is because a pulse oximeter cannot distinguish a carboxyhemoglobin molecule from an oxygen-saturated hemoglobin molecule. Because of this, we need to do an arterial blood gas co-oximetry, looking for a carboxyhemoglobin level greater than 10%. Additionally, an ECG and even cardiac biomarkers can be obtained. And it's logical to get those because of the high risk of cardiac ischemia. Remember, you're worried about this carbon monoxide damaging the brain, the lungs, and the heart. Management is centered around the use of oxygen, primarily 100% oxygen via a non-rebreather face mask. Oxygen is good because it competitively binds to the hemoglobin, while also decreasing the half-life of carbon monoxide. In fact, in select cases, one can actually use hyperbaric oxygen. For simplicity's sake, just think of this in occasions where the patient is unresponsive to initial treatment, or they're just incredibly sick. For example, our carboxyhemoglobin level greater than 25%. So in other words, default to 100% oxygen, but you can use hyperbaric oxygen. Now let's wrap up with a board-style question. A 35-year-old, otherwise healthy male presents to the clinic with headaches for the past several months. He says, "I've been spending hours in my garage every day trying to finish my custom car," and attributes his headaches to overworking himself. Review of systems is notable for intermittent dizziness and nausea. He states he does not snore and sleeps well throughout the night. Blood pressure is 140/85, pulse is 67, temperature is 37.3 degrees Celsius, and BMI is 31. Oxygen saturation by pulse oximetry is 96%. Physical examination is unremarkable. Initial laboratory evaluation shows hemoglobin of 19.8, hematocrit of 59%, and as far as platelets go, there are 234,000, 8,200 leukocytes, and EPO, erythropoietin, of 35. Which of the following is the most likely etiology of this patient's symptoms? A. Pulmonary hypertension. B. Perineoplastic erythrocytosis. C. Neoplastic proliferation of myeloid progenitor cells. Or D. Impaired oxygen delivery. Now the correct answer is D. Impaired oxygen delivery. This vignette describes a patient who has been working in his garage trying to finish his custom car and is now presenting to the clinic with headaches. And those headaches have been going on for several months, and we see on his labs significant polycythemia. Considering that his polycythemia is associated with increased levels of erythropoietin, it is likely that this patient is experiencing a reactive polycythemia, secondary to poor systemic oxygenation. Given that he's been spending a significant amount of time in an enclosed space, potentially breathing in automobile exhaust, this patient is probably experiencing carbon monoxide poisoning. Recall that carbon monoxide poisoning, among other things, leads to impaired oxygen delivery by shifting the oxygen-hemoglobin dissociation curve to the left, thereby making it harder for hemoglobin to unload the oxygen at the tissues that need it. This chronic state of hypoxemia, produced by carbon monoxide poisoning, stimulates the kidneys to produce erythropoietin in order to increase the number of erythrocytes and circulating hemoglobin. This is why option D, impaired oxygen delivery, is the correct answer. Option A, pulmonary hypertension, can occur in these patients with obstructive sleep apnea and also lead to chronic hypoxemia. And given the patient's elevated BMI of 31, this is a reasonable consideration. However, since he does not snore and sleeps well throughout the night, obstructive sleep apnea and subsequent pulmonary hypertension are less likely. Option B, paraneoplastic erythrocytosis, can be seen in a patient with some sort of cancer that produces erythropoietin. However, there was no reason to believe that this patient has cancer, as he doesn't smoke and he really doesn't have any other risk factors that are notable for cancer. Finally, option C, neoplastic proliferation of myeloid progenitor cells, is a description of polycythemia vera, and polycythemia vera can lead to erythrocytosis, but it's characterized by low levels of erythropoietin. And that's because of the negative feedback and subsequent suppression of its production because of that high level of hemoglobin and hematocrit. But in this patient, there are high levels of erythropoietin. So option C is incorrect. And that concludes our lecture on inhalation injury and carbon monoxide poisoning.